Hello, my name is Richard Montag and I will be presenting on the topic of tuberculosis, commonly called TB, which is present in Kenya in high levels related to economic migration issues. According to World Health Organization report in 2013, Kenya is one of 22 countries that are recognized as having the highest rate of tuberculosis transmission and highest burden to treat and prevent. We will explore the epidemiology with focus on the treatment, cultural considerations as to why there is such a high prevalence, and the societal impact of TB in Kenya on the global health area. TB is transmitted from host human to human by the agent Bacillus mycobacterium tuberculosis. It thrives in moist, crowded environments and lends itself to being transmitted through close droplet contact on skin or pulmonary tract. Concomitant TB and HIV have the highest level of mortality related to the disease and represent the highest levels of drug-resistant TB cases. The cost of treating the problem is not that expensive related to the treatment. However, countries that have the most wealth are not contributing to the World Fund, so the poorest of the poor can benefit from these treatments. Kenya is identified as one of the 22 countries that have the high burden of cases and drug resistance TB related to poor drug therapy completion rates and migration. Migration is a problem related to the transient global population and economies. Kenya has had a modern history of wars, famine, asylum, and migration from other countries, and is surrounded by other TB endemic countries in Africa. Tuberculosis has been substantiated in Africa for centuries. It was even found in mummies 1,000 years old. Historically, there have been epidemiological studies of TB that showed that slaves who were traded into the Americas had morbidity and mortality rates that could be cross-matched with records according to the logs on the slave ships. This also indicated that the need for study into TB and how it had spread endemically into some countries was looked again throughout the 1960s and 1970s. But it wasn't until the 1980s that Kenya developed a national program that coincided with its leprosy monitoring and surveillance programs. These programs included small treatment villages in which a person who was infected would have to be relocated with one family member permitted to go with them. This caused distrust in the community, and also Kenya decided to decentralize all of the treatment centers to serve more people locally. This decentralization allowed for churches and other groups and other hospitals in urban and suburban and rural communities to have access to care. But it also increased the need for health workers to relocate and enter in those communities. This also caused a shortage of healthcare workers in highly dense populations, and tuberculosis has always been a problem and continues to be a problem uh, nowadays with HIV and TB and multiple drug-resistant tuberculosis. TB is transmitted by droplet formation expelled by the upper respiratory system. Droplets come in contact with skin or into other respiratory tracts to cause infection. The host is invariably human, and the agent is the Bacillus mycobacterium tuberculosis. Proximity to an infected person increases risk for acquiring TB. The environment of Nairobi, the capital of Kenya, and other highly densely populated centers has caused increase in cases that are also drug resistant. According to the International Organization for Migration in 2011, the largest community resides in tenement buildings that are overcrowded, damp, and are poorly ventilated. The transmission of TB is highly affected by migration of foreign workers who are either war or hunger refugees. There are barriers to seeking treatment, and this increases transmission rates in the number of hosts in the general population. Younger people are affected more as there is more demand for cheap labor force in Nairobi. Infected persons cannot work and are forced to stay at home and expose family members to TB without treatment. According to the World Health Organization 2013, Kenya's TB rate is at 160 per 100,000, and new cases account for 89% of all the cases reported. According to the Centers for Disease Control 2012, the U.S. has a rate of 3.2 per 100,000. It is estimated that the national program budget spends $55 million on TB programs in Kenya. Only 20% is funded domestically and 15% internationally, which leaves 61% underfunded per the World Health Organization 2013. This disparity does lead to question the amount of new cases that are untreated in Kenya, and the incidence rate may actually be higher. The impact of TB is quite severe in high-burden countries such as Kenya. Migrants that flee from war-torn countries or countries that are in famine result in a migrating population of newly available hosts, especially in Kenya. These new immigrants may be uneducated or lack the resources for TB detection and treatment. There comes several societal concerns that include access and barriers to this treatment, according to the International Organization for Migration in 2011. The new cases increase poverty related to diseased persons unable to work and may cause gender inequality related to women who will be unavailable to work or care for children while infected. The number of transient population will continue to rise as the number of immigrants increases with the hope of economic resettlement. The overall health of the country will decline, and the economic impact will burden the labor force related to less workers in the workforce. This will present a problem as Kenya is underfunded for actual TB prevention and support. This will also burden the labor force related to less workers being able to work and comply with medication treatment regimes. Increased mortality rate also imposes a burden on the treatment centers outside the high-density TB areas if allocation of resources to combat at a higher rate of incidence is not available. There are several treatment and prevention programs currently in place in Kenya. First line of defense is empirical medication treatment, which uses rifampin to treat individuals who come in contact with the tuberculosis disease. They're also monitoring of new cases in prison systems and other densely populated areas. They use a collaborative healthcare system to monitor and surveil and treat people who may or may not have concomitant diseases such as HIV. And then, of course, accurate diagnosis through testing kits that are supplied throughout the communities. Prevention consists of decentralization of a national healthcare system to implement rural and urban and suburban treatment centers, also giving availability to access to care. Prevention also includes access to quality medications that are purchased on the world market through funding sources of the World Health Organization. This increased funding and surveillance sources has helped in treating tuberculosis. However, with the influx of migration related to migratory process, it has been overburdened and is severely underfunded, as you will see in a bit. Several factors and cultural considerations in Kenya that prevent treatment and also delay treatment. One of the areas of concerns, according to World Health Organization 2013, is mistrust or treatment of tuberculosis related to the TB villages. These centers were established far and away from urban centers, and people were relocated there to spend 6 months in treatment with monitoring surveillance. They were allowed to take one family member to reside with them, but they were separated from the population. After the 6 months, they were then given a 4-month supply of medications and then could leave the compound. Although it did decrease the rate of incidence and also decrease the rate of multiple drug-resistant tuberculosis, it caused distrust in the overall national healthcare system. The other area is the male-centric workforce. According to the IOM 2011, there is an increase in male workforce that leaves women unavailable to work. This also increases the rate of incidence of transactional sex and other things that are causing HIV to skyrocket in Kenya. HIV and TB have the highest morbidity rate and mortality rate than any other combination in Kenya. Funding is not supported for treatment. There's only there's 61% of the budget's unfunded, as you will see, and quality of the medications in questions as far as what type of quality of meds Kenya is getting currently. Several global and health agencies are involved with Kenya currently. The World Health Organization, of course, assists with planning and budget for TB program and gives primary funding for primary and secondary prevention programs. Global Fund to Fight AIDS, Tuberculosis, and Malaria, the GFATM, also gives financial grants and resources for TB and has given $44 million US dollars since 2003. Thank you for listening to my presentation. These are my references to the presentation. Again, Kenya is slowly trending towards coming out of being one of the top 22 burden countries related to TB treatment and prevention. They use primary, secondary, and tertiary programs for intervention. And also, they have made huge gains, but are still having problems with multiple drug-resistant tuberculosis. This, according to World Health Organization 2013, is related to the HIV and TB resistant and migration populations that are involved with this disease. Thank you and have a good day.